Good morning, everyone. Thanks so much for taking time out of your busy day to join me. Today is our last webinar with the Hospital-Acquired Infection Superset Jumpstart series. So for those of you that have been on all 6 of the webinars, thank you so much for your attendance and commentary. And for those of you who are just joining for the first time today, I hope you find the information valuable. So with that, we will go ahead and get started. Just a couple of housekeeping tips, if you will. Please make sure to mute your phone lines. Don't place the call on hold. Utilize the chat box for questions and responses, and this session is being recorded and will be sent out in a day or two after we've finished the webinar. So with that, I just want to give a quick update on what jumpstarts are. So jumpstarts are opportunities for facilities to gain fresh ideas, provide peer perspectives, energize your teams, and stimulate action around your infection prevention efforts. You will notice that on the Zoom platform, you have a box down at the bottom of the chat box. And if you see that little box, click on it and make sure that you have selected all panelists and attendees. As you can see here. And then if you have a question, you can enter that into the chat box. I'll be monitoring the chat box today as we go through the slides and try and get answers to your questions. And hopefully, if I don't, someone on the line will. This is your opportunity to share and collaborate with each other. Not everybody knows everything, and this is a great forum to get us all on the same page and take fresh ideas from each other. So we'll do a little bit of practice with the chat box. So if you could enter your name and the facility that you're with into the chat box. Hi, Sherry. Morning, Michelle. Hi, Lana. Hey, Karen. Hi, Lex. Joni, thanks so much for your form that you sent us, your screening tool that you sent us last week. It was fantastic. Hi, Joyce. Morning, Stephanie. Hi, Deb. Nancy, Kara, Jenna. Morning, Kate. Hi, Stephanie. Thanks so much for joining us today. Okay, just to get to know you a little bit, how many of you have your Christmas tree up? And if you don't, you do, okay? I'm seeing several people have it up, several not. When do you usually put it up if you don't have it up? After Thanksgiving. Yeah, I usually take the Friday after Thanksgiving and put mine up too. Do any of you put up more than one Christmas tree? I have a friend who puts a tree up in just about every room. The only room she doesn't is in the bathroom. Lonnie, you put up more than one. Jenna, 6 trees. Wow, I'm impressed, girlfriend. A big one and a little one. Oh, Maggie, you put yours up last night. Your daughter made you. That's funny. Only one because you have a cat that's naughty. Oh, Karen, yeah, I've had one of those naughty cats too. So, well, that's interesting. Thanks for sharing, ladies. I usually put mine up the Friday after Thanksgiving, and it comes down the day after Christmas. I just can't stand the clutter that it brings. So it is what it is. What are you going to do? All right. So let's get started. Our objectives today are to talk about the measure definition, the numerator, the denominator, and the denominator exclusions. I want to talk a little bit about sepsis bundles. I've got some examples of screening tools, and then talk a little bit about barriers and successes on how to overcome those. And I'll be interested to hear anything and everything you ladies can share about this. I hear quite often that this seems to be a struggle for facilities, whether it be an education piece, whether it be a electronic health record piece, whether it be fully understanding what the sepsis measure is looking for, and then how to really adhere to what the bundle practices are. So again, this is an opportunity for all of you to share, and we'll just get started. So the why behind monitoring sepsis or ensuring that we are adhering to the bundle elements. Again, post-operative infection is defined as any infection that occurs within 30 days of operation and may be related to the operation itself or the post-operative course. It can involve the wound. It can include deeper infections within the body cavities or distant type infections such as pneumonia and or CODI. Sepsis remains one of the leading causes of death. It accounts for 1/3 of all sepsis deaths, and sepsis creates a significant clinical and resource burden to hospitals. 15 million surgeries are performed annually in the U.S., and when you're talking about 1/3 of sepsis deaths occurring out of 15 million surgeries, that's a hefty number to really address and think about. The next slide we're going to talk about talks about the AHRQ PSI 13 post-operative sepsis rate. Now this is a slide that I copied from the AHRQ website itself, and it is an analysis of discharge data from 2016 AHRQ healthcare cost and utilization project from state inpatient databases. So while this is a couple years old, and that's typically how AHRQ works, you can see that the description of the various pieces that they look at, it still really is quite a hefty rate. So overall, there were 14,125 cases that were reported with a denominator of almost 3.5 million. You can see that the 40 to 60-year-olds were more impacted than 18 to 39, again followed by the 65 to 74, and then 75 plus. And again, we know that that's probably attributed to, or some attribution to, those folks having additional comorbidities. But it's eye-opening when you look at those types of statistics. And so when we're talking about this particular metric, what it's looking at is post-operative sepsis cases with a secondary diagnosis per 1,000 elective. And so I want to clarify that. It's elective surgical discharges for patients that are 18 years and older. So cases that are excluded from this particular measure are patients with a principal diagnosis of sepsis, cases with a secondary diagnosis of sepsis that is present on admission, cases with a principal diagnosis of infection, cases with a secondary diagnosis of infection present on admission only if they also have a secondary diagnosis of sepsis and obstetric discharges. So remember, those are exclusions within this metric. The numerator actually is looking at discharges among surgical cases that meet the inclusion and exclusion rules for the denominator with any secondary ICD-10 diagnosis code for sepsis. And then the denominator, again, is elective surgical discharges for patients ages 18 years and older with any listed ICD-10 procedure codes for an operating room procedure. And again, we have this all spelled out in our toolkit. So if you have questions about that, you can reference that, or you can contact your clinical quality consultant here at IHC. This data is picked up through the inpatient, outpatient database, so it is based off of claims data. And so I would hope in most cases that you folks are aware, the IPs are aware of those cases coming in before it ever shows up on your claims data. Just a question for you folks. How easy is it for your billing office or staff to communicate to you that they're concerned about a possible SSI? Do you do weekly meetings or huddles? Do you have a electronic tool that alerts you that this patient may be included as a potential post-op sepsis or infection, or how does that work for your facilities? Okay, Stephanie, you indicated that you're not sure they would even know, that you believe it's just coding and surveillance. Okay. Nancy, you indicated that staff may email you, but you only find out when you review culture reports later. Okay. Maggie, you indicated billing doesn't notify your IP. Utilization review does notify infection prevention if it's noticed on chart review. Jenna, you indicated infection prevention, nurse surveillance. Lana, you indicated that EHRs will trigger and often discussed at huddles. Yes, I agree with that. Jenna, when you're talking about infection prevention, nurse surveillance, can you elaborate on that just a little bit? Are you in the charts every day? Do you follow those patients for 30 days after discharge? What does that look like for your facility? Culture monitoring daily and then 30 and 90-day reports. That's what I'm used to as well. And so I didn't know if that was something that was pretty much adhered to for most facilities, or if others had other mechanisms in which to capture that. So thanks for sharing. Okay, so the sepsis bundles. Let's talk a little bit about that. We have the 1 hour bundle, we have the 3 hour bundle, and we have the 6 hour bundle. The 1 hour bundle, I know through a lot of facilities, a curveball, if you will, because a lot of facilities were concerned that they wouldn't be able to meet that metric. if you remember, it's very similar to the ideal treatment for when folks who were having heart attacks came out, where you had to have the EKG within 10 minutes and aspirin had to be given within the first hour of arrival, and an IV with labs and nitroglycerin and all of those pieces. So the 1 hour bundle really is just pushing the envelope, if you will, on what the 3 hour bundle used to be. So when it comes to the bundles, just remember the clock starts once the patient meets the sepsis diagnosis or screens positive for sepsis. And so for patients who present to the emergency room, the 0 hour begins at the presentation to triage. For inpatients, the 0 hour is when the patient's vital signs first meet Sears criteria and indicate the presence or suspicion of infection, regardless of when it was recognized or treated. And so as I was doing my research for this webinar, I saw where there's facilities that now have identified sepsis coordinators, or they've tasked their rapid response teams or their MET teams with monitoring this metric. And so what is it that you folks do when you have somebody that could potentially be coming in with sepsis? Do you throw a MET alert? Do you throw a rapid response team? Do you have a sepsis coordinator? How is that handled for you guys? I've never been in a facility that has had a sepsis coordinator. I have worked in a couple of facilities that have a rapid response team, and then I worked in one facility that had a MET team. And the expectation was that the rapid response team and or the MET team were immediately called whenever there was a suspicion of sepsis. So, Stephanie, you indicated that you do not have a sepsis protocol. Okay. Well, hopefully we can get you some resources today that will provide you with the potential of setting up a sepsis protocol. Maggie, you indicated that it's physician-driven. Joni, you started doing sepsis alerts much like stroke alerts in the ED. You're designing a process for infection prevention now. You do have a stroke coordinator, but she doesn't always respond. It's interesting that you say that, because the facilities, or when I was doing research and I was reading about it, about the sepsis coordinator, there wasn't much in there about the sepsis coordinator always responding to a sepsis alert, if you will. They felt that with the education that the sepsis coordinator provided the team, that they would be able to be the first responders, if you will. The sepsis coordinator was primarily there to look at the outcomes and ensure that the protocols and parameters were met for the patient on retrospective review. Nancy, you indicated that the nurse and the physician have responsibility to identify and act on the symptoms, and I would agree with that. I think sometimes our folks get a little concerned if there is a MET team. I can't say concerned. They get a little, and I don't even want to say standoffish, but it can be sometimes off-putting to staff if they've never been involved in a MET team call or in a rapid response call. And so I think the education piece is huge when it comes to the expectation of how staff should respond. Um, so let's go on and talk a little bit about what's involved with the 1 hour bundle. The 1 hour bundle, it's recommended that you measure lactate, and if it's greater than 2 millimoles per liter, that you remeasure it. You obtain blood cultures prior to administration of antibiotics. Administration of broad spectrum antibiotics is best. Rapidly administer 30 milliliters per kg of crystalloid for hypotension or lactate greater than or equal to 4 millimoles per liter. Utilize vasopressors if the patient is hypotensive during or after fluid resuscitation to maintain mean arterial pressure of greater than or equal to 65 millimeters of mercury. And then just remember that CMS requires hospitals to report post-operative sepsis as a hospital-acquired condition. So let's talk a little bit about the lactate. The serum lactate is an indicator for tissue perfusion. And some of the studies that I reviewed showed that a significant reduction in mortality occurs by lactate-guided resuscitation. So in other words, you are really using the lactate result to guide the treatment plan for those particular patients. If the lactate is greater than 2 millimoles per liter, then you remeasure within 2 to 4 hours to guide the resuscitation. One of the questions that I had is, how many facilities have point-of-care testing for sepsis in their ER? Maggie, you indicated that you don't have point-of-care testing in your ER for sepsis. I suspect that a lot of facilities don't have that just simply because they have a lab that's very close. And yes, Nancy, I'm referring, excuse me, I'm referring to lactate point of care. Joan, you indicated that you don't have point of care testing, but you have reflex testing if the initial lactate is elevated. Steph, or Jenna, I'm sorry, you indicated that it's an ongoing discussion at your facility. Okay. The blood cultures. Just a couple questions for my knowledge. How many of you have it set up where lab draws all of your blood cultures, or is it a mix where nursing and labs draw your blood cultures? Stephanie, you indicated only lab. Nancy, you indicated that lab does it unless it's from a central line. Joni, you indicated lab does. Jenna, you indicated that it's primarily lab. Yeah, that's what I'm used to too. It was interesting in the literature that I read through in creating this webinar. It was kind of a mix between nursing and lab. One of the facilities talked about how with nursing, initially what they were finding was that they were having problems with contaminants when it came to the blood cultures. And so that was why they switched to having lab draw all of the blood cultures, because they didn't want to run the risk of having a contaminated specimen. So it's good to know. Thank you. Again, just just a note about the fluid resuscitation. It's recommended that the fluid resuscitation be completed with 3 hours of recognition, so that's the 0 hour. Fluid resuscitation beyond the initial resuscitation should be carefully monitored to ensure fluid responsiveness. And I know several of you indicated last week that sometimes you've got issues with providers not wanting to adhere to the fluid resuscitation for sepsis patients because they're afraid of throwing them into heart failure. So I will tell you that's going to be a sticky wicket. I will say that I think the providers that are currently coming out of school and have had more exposure to sepsis and sepsis protocols do a better job of adhering to the fluid resuscitation piece than older providers. And you can argue that it's experience. You can argue that it's, that it's just a change in practice. I think there's opportunity around the fluid resuscitation piece and worthy of discussion with medical staff and hearing all of their views. Certainly if you've got those folks that have the pre-existing comorbidities and are dealing with sepsis on top of, say, the diabetes or the congestive heart failure or, the respiratory conditions or certainly kidney conditions, it's certainly worthy to explore whether it would be most beneficial for those folks or not. Setting up protocols is definitely a helper in that, in helping guide surveillance and potentially after action. So vasopressors are usually started within the first hour if you're dealing with severe sepsis and or septic shock. So that's where you're getting into that organ perfusion dysfunction and really wanting to make sure that those patients have the perfusion in order to sustain. So just out of curiosity, within your order sets, do you have a prescribed regimen of what vasopressors you start with? Do you start with norepinephrine, or do you immediately jump to some other type of vasopressor? Is it physician driven? One of the other things that I want to just touch on a little bit is, what are you seeing with your nurses and your providers? Do you notice a difference in their knowledge base when it comes to sepsis? And how do you provide that education to your staff? What does that look like? Nancy, you indicate that you don't have an order set and that it's only physician driven. And I agree with you. You indicate that it's hard to have protocols because there's issues of maintaining them. That is so true. Joni, you indicated that you've got a protocol you follow and that the nurses can start the protocol with a specific list. Jenna, you indicated that you've got the vasopressors listed within your order sets. You offer 2 options of norepinephrine, and that there's one other one, possibly Levocet. Mm-hmm. So just out of curiosity, have any of you defined or have you started on any type of work body of work surrounding sepsis at your facilities? I know a couple of you indicated that you're just starting to look at a few different pieces. What do you hope to have accomplished within the next, say, 3 months and 6 months when it comes to sepsis in your facilities? Maggie, you indicated that you're using your Jumpstart to kick off your sepsis work group. Thank you. I'm glad to hear that. Is there any other body of work being done by facilities surrounding sepsis? Have you developed computer-based learning modules for your staff, or have you set up some type of unit-based teaching, or does this become part of your skills fair? Nancy, you indicated that you have a HIIN bedside leader for sepsis and that you work together to identify issues and make changes. Joni, you indicated that you're going to be starting a code sepsis on the inpatient side, and that you're doing intensive meetings to review your metrics, fallout, and tweaked your best practice alert model to fire more efficiently. I'll be interested to hear how that goes for you. Maggie, you also indicated that you got a physician advisor planning to speak at a physician meeting. That's fantastic. So it sounds like there's some good progress being started out there. I'll be interested to hear from all of you on how that work goes. So moving on to the 3-hour bundle. Again, this is just a infographic that talks about the 1-hour bundle that I would encourage you to shamelessly steal. It comes from the Surviving Sepsis campaign, and it's just a quick 1 through 5 step piece that can remind staff of what's involved when it comes to the sepsis bundles. So talking about the 3-hour bundle, measuring the lactate again. So remember, it's within that 2 to 4 hour range after initial presentation, or 0 hour as they call it. Again, ensuring that you've obtained blood cultures, that there's been administration of broad spectrum antibiotics, you've got the fluids on board, you're addressing the hypotension, you're utilizing vasopressors. Just remember that when it comes to the 3-hour bundle, that it's primarily used to distinguish between SIRS and severe sepsis. What I'm reading from the Sepsis Alliance is that severe sepsis is kind of going away, and it's being morphed into that organ perfusion dysfunction, and then you move into septic shock. And so when you're getting into the 3-hour bundle and then also getting into the 6-hour bundle, your targets for quantitative resuscitation include a central venous pressure of greater than 8 millimeters of mercury, or a SCVO2 of greater than or equal to 70%, and normalizing of the lactate. That's probably the biggest piece that you really want to see happen, is that the lactate is normalizing, and that you are reducing through fluids, you're reducing that potential for end organ damage or multi-organ failure. So the 6-hour bundle, again, it just goes into administering vasopressors. If the patient's hypotensive, you want to make sure that you're maintaining a mean arterial pressure of greater than or equal to 65 millimeters of mercury, that you're maintaining that CVP greater than 8, and that you've got the central venous oxygen saturation of greater than or equal to 70%. And typically what I see with this is that this is being done through an ART line. It's being done through central monitoring. I know, Maggie, you had indicated last week if there were alternatives to measuring these pieces if you didn't have an ART line in place. I would throw that out there with everybody that's on the line. In my research, I didn't find any alternatives, but what do others say? Is there any other alternatives to measuring CVP without having an ART line? The other thing that I would ask is, what is your cutoff of keeping a patient at your facilities when you determine that they need to move to a tertiary level of care and that it's beyond your realm? How do you handle that? What are your guidelines? Nancy, you indicated that you don't have an ICU and that you don't put in ART lines. Patients are transferred if they need it and or family requests aggressive treatment. Okay. And that's been my experience too, is that it was really, if we saw that a patient was headed towards that end organ failure, we did our best to stabilize them and then attempt to get them out of the facility if family so choose or the patient chose. Michelle, you indicated that it's based on physician comfort level and family wishes. Stephanie, you indicated that there's that you don't have an ICU or the ability to monitor, so you would transfer. Yeah, it makes it tough in rural Iowa because we don't have the resources that the urban facilities have. You know, we may have all the knowledge base in the world and we can always call and we can do telemedicine, but it's really getting down to the potential resources that are available at those critical access hospitals and how they can support their staff and still do what's right for the patient. Yeah, I've run into that too, Maggie. It's tough, you know, when the patient, they say that they want everything done, and then when things get bad, then they change their mind. It's not an easy decision for families and or providers to make in those types of cases. So let's talk a little bit about the types of screening tools that are out there. You know, we're all familiar with the SIRS. That's kind of what started all of these pieces when sepsis first started becoming known and really determining that it has a high rate of morbidity and mortality if it's not addressed. So remember, the SIRS is the Systemic Inflammatory Response Syndrome, and it had those 4 key elements of where the patient presented with a heart rate greater than 90 beats per minute. They had a respiratory rate greater than 20 breaths per minute. They had a fever or hypothermia, leukocytosis of greater than 12,000 or leukopenia of less than 4,000 or bandemia of greater than or equal to 10%. And patients that were classified as SIRS had to meet 2 or more of those criteria. And so one of the things that the Surviving Sepsis campaign recognizes is that those 4 elements really still do a very good job of helping to screen and potentially identify those patients that are moving on through that sepsis cascade. So they recommend that you still kind of look at what those pieces are. just out of curiosity, with your facilities, do any of you still use the SIRS criteria? Do you still find the best practice alert firing when it comes to alerting you for SIRS criteria or alerting staff providers for SIRS criteria? Okay, I'm starting to see several facilities are still using SIRS. Yeah, and I will tell you, when I practice bedside, we use the SIRS criteria as well. It just seemed to be the one that staff was most comfortable with, and it gave clear criteria and expectations. Maggie, you indicated that the physicians often use SIRS and that your best practice alerts are based on SOFA. I'm glad you brought that up. We'll talk about that in just a couple minutes. Joni, you indicated that you still use the SIRS, but you've had to tweak it so that it doesn't overfire. And that's a good point you bring up. Sometimes when we have these best practice alerts, it's no different than alarm fatigue. You can be alert fatigued as well and just miss those things because it's just constantly firing. So I'm glad to hear that you have truly honed in and addressed that piece. What types of things did you do to tweak your BPAs? Did you further define your criteria on when it would actually fire? So we'll move on and talk a little bit about this LODS, L-O-D-S. Out of curiosity, have any of you heard of this? I hadn't heard it when I was doing my research, so I found it kind of interesting. It's an acronym for Logistic Organ Dysfunction System, and it's a system identified from 1 to 3 levels of organ dysfunction based on 6 organ systems. That's a mouthful. Neurologic, cardiovascular, renal, pulmonary, hematologic, and hepatic. And what happens with the LODS system is that 1 to 5 points are assigned based on the severity level of the dysfunction within the organ system. Scores range anywhere from 0 to 22, and it's primarily developed specifically for ICU patients. So I just found that it was kind of interesting. The research that, or I should say that the studies that identified that they had used this in their populations found that it really had a high specificity and a high sensitivity in identifying patients with sepsis and then potentially further identifying morbidity and or mortality based on the scores. So I found that kind of interesting. Back up to the SIRS criteria, Joni, you indicated that that you did define the criteria and that your specialist with IT MD change the specificity. So I'm glad to hear that. That sounds really interesting on what you've done, and the fact that you've had a 75% improvement, I think, speaks volumes to how you really have been able to hone in on that criteria. So Maggie, you indicated that you use the SOFA, and the SOFA is the Sequential Organ Failure Assessment. It has a 0 to 4 level for each of the organ systems: respiratory, coagulation, hepatic, cardiovascular, neurologic, and renal. Within the respiratory system, it's looking at what the PO2 is and what the FiO2 is. For coagulation, it's looking at platelets, trying to determine if that patient going into DIC. For hepatic, it's looking at bilirubin. For cardiovascular, it's looking at mean arterial pressure. The neurologic is the Glasgow Coma Scale. And then for renal, it's looking at the creatinine. In the research that I did, I found that most hospitals will utilize this in their ICU, their CCU, and their SCU. Maggie, out of curiosity, do you guys also use this in your ER, and whether you're trying to determine if they need to be transferred or not? Yes, okay. In the ED, okay. Do any others use the SOFA tool in their ER and or their inpatient units? I'll be honest, I had always heard of SOFA, but in my experience, when I've looked through medical records, I wasn't able to ascertain whether it was SOFA or whether it was just a homegrown through whatever the facility had developed in their EHR. Nancy, you indicated that you hadn't seen it, but thought, or in your facility, but you had seen it through a contracted ED physician chart with it. Okay. One of the other tools that I discovered when I was doing research for this and the Sepsis Alliance speaks to is called the Q-SOFA, or it's the Quick SOFA. So again, it's the Quick Sequential Organ Failure Assessment, and it really is very simple, and again, is just a quick one-stop, hey, I think this patient may be progressing into organ failure and or septic shock. So it looks at 3 components, and each component is worth 1 point. So it's a respiratory rate of greater than or equal to 22 breaths per minute. It's a change in mental status, and a systolic blood pressure of less than 100 millimeters of mercury. So what I did find with this Q-SOFA is that the studies indicate it has poor sensitivity but equal specificity to the SIRS tool to identify organ dysfunction. And so essentially what I found when I was reading through some of this is that if you're going to use the Q-SOFA, it's great as a screening tool, but it's not as great as the SIRS criteria. All right, so this is just a something that I found off of the internet. So it comes from mdcalc.com, mdcalc.com, and what this is it's an electronic way to complete the SOFA calculator. So again, it's looking at the respiratory, it's looking at the cardiovascular, it's looking at the renal, and it goes through and then it will assign the score. And then down at the bottom, as you can see, based on what you plug in, it will give you a result and tell you whether this patient is moving more towards organ dysfunction, septic shock, or whether you can just continue to monitor them. Within the MDCalc website, it also has a Q-SOFA calculator. And so again, as you can see, it speaks to if the patient's in the ICU, if there's altered mentation, what the respiratory rate is, and then what the systolic blood pressure is. So just a couple of resources for you folks to go into and take a look at. Through the Sepsis Alliance, I also was able to find some tools and examples for you to take a look at. And so this is through the University of Pittsburgh Medical Center. It's quick, simple, and to the point. it goes through and it talks about, so the acronym is CAF, were culture sent, was an antibiotic administered, when was it hung, was a lactate sent, and then was a second lactate done within 4 hours if the first lactate was greater than 2, and then fluid resuscitation. So Maggie, I know we had talked about not having central venous pressures, but I think your bigger piece for facilities that don't do ART lines is really looking at that mean arterial pressure and making sure that it's at least 65. So that could be a tool that you could potentially use, or criteria that you could potentially use to determine whether the treatment is effective for those types of patients. And then on the back side of this particular half sheet, it talks about what the vital signs are. Apparently they have something within their electronic health record that's called a power plan, but then it also goes on to specify what those initial antibiotics should be, that broad spectrum antibiotic. So just a quick down and dirty to get you started there. The next tool that we'll take a look at is from Cookeville Regional Medical Center in Tennessee. It talks about the whole sepsis cascade, where severe sepsis is defined as, it gives definitions. It talks about what the sepsis screen involves. It talks about what your goals are within the first 1 hour or the 3-hour bundle. And then it goes into the septic shock, and then, a nice little pathophys thing for me as an old nurse, I'll put it that way, talking about stroke volumes. I also like the little algorithm down at the bottom where it talks about time 0, ED arrival or direct admit arrival to hospital, and then gives that little algorithm. So these are all things that are out there under the Sepsis Alliance that you can go out and pull and potentially either use as is or tweak to fit your needs. Another one that I came across was St. Joseph Mercy out of Michigan. And so patient units severe sepsis screening tool. And again, it goes through and it talks about the Sears criteria. It talks about where the suspect infection is. It talks about organ dysfunction. And then again, gives a nice algorithm down at the bottom and what should happen. Now you can see from this particular screening tool that they also have a code sepsis. So it's again, just another opportunity to take a look at and identify if bits and pieces of these can help you set up your own protocol. And again, it's out there under the Sepsis Alliance campaign. So I see we're getting close to the end of our time. I've got just one other slide that I want to share with all of you before we get into resources. I know that when you're looking at developing a new program or a new protocol, you are faced with a ton of barriers and how to overcome them. And last week I discovered a article through the Society for Critical Care Medicine, and it had a very nice table that talks about sepsis bundle indicators, barriers to achievement, and potential solutions. So I will make sure that this gets sent out to all of you when the webinar link gets sent out, but it really does a nice job of defining what those barriers are and then potential solutions that you can use. So I'll send that out so you'll have that. Just know that with, when you've got competing priorities, when it comes to setting up a new protocol or a new procedure, that really defining what the guidance and having order sets available to staff will help quell that fear, if you will, of developing a new procedure or protocol. You know, one of the things that this article talked about was the inability to start IV or obtain blood for labs or cultures. You know, considering IOs, you're not able to do central venous lines or ART lines, but you can certainly do IOs. And so that would be another way to really start looking at, this is what our barrier is going to be, but these are the other options that we have. So potentially doing a barrier success tool for staff can assist with that. Having insufficient knowledge, you know, keeping the education to the forefront. The Sepsis Alliance has a great resource when it comes to defining best practices and how facilities can overcome those challenges that they face. And I will tell you, the Sepsis Alliance is available by phone call, available by email, and really do want to see facilities succeed when it comes to developing their sepsis program. You know, again, insufficient knowledge of the importance of the lactate. You know, doing education with staff and defining that whole pathophys thing with them and saying this is what our outcome is intended to be. And so really getting them on board and having them understand those processes. Having a multidisciplinary team to look at all aspects when it comes to sepsis. You know, how does it impact lab? How does it impact radiology? What do you do if you're hit with a trauma and you've got a sepsis patient and then you've got a code on the floor? You know, how does your rapid response team tie into that? How does your MET team tie into that? Do you have a sepsis alert? So thinking about all of those things. One of the things that I did see when it came to talking about caring for that sepsis patient is considering flexing those staff. So not necessarily dedicating staff one-to-one with a potential septic patient, but making sure that when that septic patient comes in, that nurse only has one other patient potentially that they're looking after. Or if you have the capability, dedicating that nurse to that patient's bedside for the first 3 to 6 hours. That might be a way to overcome that. You know, and one of the other things that it talked about was the unavailability of nurse or provider to perform the reassessment. And so while it's best to have a provider assisting with that reassessment, you know, potentially looking at within your policy and your procedure, is it possible to set that up within your protocols that Nurse Jones, you need to make sure that you redraw that lactate at 4 hours and that Dr. Smith has the capability of reviewing that result within 30 minutes and then adjusting care within those guidelines. So it's really identifying what the priorities are for your organization and then how you can coordinate among your multidisciplinary team to ensure that all of those facets, all of those steps occur. What questions do you folks have? What ideas do you have to overcome some of these barriers and challenges that facilities run into? Have any of you identified leads or champions for the sepsis protocols or alerts? I know some of you indicated that you've got an advisor or you've got your house supervisor or your HIIN lead that monitors that. One of the suggestions that I had that I always found effective was if you're looking at developing a protocol or a procedure, you know, considering your nurse residents, if you will, or those staff who are looking to, you know, do their capstone project for their bachelor's or potentially do something within their master's program. You know, some facilities have set this up where they have a career ladder, if you will, and facilities or staff can then sign up to say, yes, I want to help the infection preventionist develop this, or I want to help the HIIN lead develop this. So just some ideas to think about as you get ready to set up your program or embellish your program to make it more robust. Joni, you indicated that it's been a process at your facility and that it's important to learn from past fallouts. I so agree. Your outliers can really help define what education and shortcomings there are in meeting your policies and your procedures. You indicated that you have champion MDs and RNs, and I like that too. I think having staff feel an ownership, if you will, on what some of these processes are can really help drive the success of those types of programs. So I will show you what the resources are, and again, these are going to be attached to the slide deck and will be sent out with the slides as they go through. A big thank you to all of you for taking time out of your busy schedule. I hope you found value these last couple weeks as we've talked about sepsis, but then also the last 6 weeks as we've talked about other healthcare-acquired infections. That's all I have. Thanks so much for your time. Enjoy your Thanksgiving holiday and reach out to your clinical quality consultant if you have questions, concerns, and take care. Thank you.